Thank you. It is indeed an honor and a privilege to be here with you this afternoon in what my partner and I hope will be a meaningful sharing experience of our program, of one of our programs in an existing community health center. My name is Chris Esperat, and I'm Associate Dean for Clinical Services and Community Engagement at the School of Nursing in the Texas Tech University Health Sciences Center in Lubbock, Texas. That's a very long designation. And I'm an associate professor, and I also oversee what I consider a robust practice program. And I'm going to ask Linda to introduce herself.
Hi, I'm Linda McMurry. I'm the Executive Director of the Larry Combest Community Health and Wellness Center, which is the big overarching program that we're going to be talking about today. I'm also an adjunct or a faculty member at the Texas Tech School of Nursing. I'm an assistant professor at this point. So we are delighted to be here and share our community health worker experience with you.
Before we go ahead and get started with our dialogue, I'd like to get a sense of who is here among the audience. I know that there probably is a significant number of provider types, but I would like to know if there are consumers and residents of the different programs that we have. So how many of you here are residents and consumers? Very good. I talked to both of them before we actually started, and I told them how glad I was that we are going to have the perspective of the consumer, because I think that that is a very important part of our getting a sense of the success and the outcomes of our program. How many of you here are primary care providers? 1, 2. Very good. How many of you here are administrators? Significant number. And the rest of you are?
Public health.
Public health. Okay. Well, it sounds like we've got a good smattering of distribution of folks who would have some concepts and some interesting perspectives on the topic that we are talking about today, which is the effects of community health workers on chronic disease self-management. So before we go ahead and discuss the nitty-gritty and drilling down of the whole idea of community health workers for chronic disease self-management, I thought to give us a context to share with you what the objectives are. First of all, we would like to discuss the role of community health workers in chronic disease self-management. And I know that many of you have had some exposure with community health workers. Am I correct? How many of you here have actually worked with community health workers? Oh, okay. Well, I hope that our discussion today will give you an insight on what the role of this workforce, this part of the workforce is, particularly because with Affordable Care Act, we think that there will be a much bigger role for these groups of people. And then we would like to share with you the Transformation for Health, which is the conceptual framework around which we developed and implemented and evaluated the community health worker patient navigation program. And then we will discuss the infrastructure and services of the patient navigation program. And then last but not the least, we'll share with you the clinical and behavioral outcomes of the program. So the setting for this is the Larry Combest Community Health and Wellness Center, and I will ask the executive director of the center to give a discussion to share with you what this program is, what this center is all about.
And forgive us as we keep playing tag team here. Okay, so the Larry Combest Community Health and Wellness Center is a nurse-managed center. It became a federally qualified health center in 2009, but it's been in existence as a nurse-managed center since 1998. You can see a picture of our building up in the top right-hand corner here. It's about a 6,600 square foot building. We have 8 exam rooms. We were very fortunate last year to be awarded one of HRSA's $5 million capital improvement grants. So the building doesn't look like that right now. It's in the process of being renovated, torn up, and added to. So we will be able to have 22 exam rooms at the end of construction. So, of course, as a federally qualified health center, we are funded by the Bureau of Primary Health Care under HRSA, and we're very grateful for that funding. Initially, our organization was established in 1988, and it was for our Texas Tech University Health Science Center Student Health Services. But we decided to change our focus in 1998 to provide primary care to a very vulnerable, medically underserved population in the very east part of Lubbock. We are a nurse-managed center, but we are a public entity model because we are connected to the School of Nursing at Texas Tech University Health Science Center. So to make that relationship work, we do have a 501c3 governing board that's like any other FQHC. It's made up of 51% consumers on our board. And that's where the co-applicant comes in. Texas Tech University Health Science Center and the Combest Board have a co-applicant agreement which binds the two together and delineates their responsibilities. The Health Science Center is basically the fiscal intermediary. They do all the grants, and the dollars flow through the Health Science Center into a Health Science Center account. But the board of directors actually makes those decisions about the programs and the operations and the hours of service that we have. So it was actually started by the School of Nursing and administered through there. All of our employees are employees of the Texas Tech Health Science Center, which is really one of the greatest benefits, I think, to a public entity model. If we were this small of an organization with only 50 or 60 employees, it would be really costly for us to provide insurance and all the great benefits that they get as state employees. So that's a great perk. So we have 4 main programs in our FQHC. 3 are in the FQHC and 1 will hopefully be in the FQHC. We provide primary care for children and adults, all ages, in the clinic setting. We have a senior house calls program, which is a little bit unique. We provide primary care for seniors or vulnerable people in their homes. The real requirement is that they have difficulty getting to a clinic-type setting. So we provide nurse practitioners and also a licensed clinical social worker to make home visits to provide their primary and behavioral health care. We have about 300 patients on that program, and right now about 4,500 in our clinic setting. We also have the only accredited diabetes education center in Lubbock, and that program is operated by a registered dietitian who is also a certified diabetes educator. In addition to seeing clients in the clinic, she will do group visits, one-on-one visits, and also make home visits to our vulnerable population if she needs to. One of our newest endeavors is Sunrise Canyon Integrated Behavioral Health Services. We partnered with our local MHMR about 4 years ago and applied for a SAMHSA grant because they provided outpatient ambulatory care psychiatric services. And there was just such a huge need because if you look at the patients with serious and persistent mental illness, those patients tend to die 20 to 30 years earlier than the normal population. One of the main reasons being because they do not receive primary health care. So we thought if we would put primary care into their existing care location, that would improve their access to care. So we've been running that grant for about 2 years and are very happy with that. At this point, it's not part of the FQHC, but we did submit a new access point application back in March. So the primary health care clinic is what you would typically think of. We see adults and kids. We do a lot of sick visits and well visits. The Medicaid Texas Health Steps checks is what it's called in Texas, but physicals of all ages. A lot of immunizations. We do some minor injury care. We do a little bit of suturing and wound care, that kind of thing. But we also specialize in chronic disease management, and that's really where we feel that our nurse practitioners really shine. Being in a medically underserved area, and especially in our location, we have a tremendous number of patients who have diabetes, hypertension, asthma, obesity, and congestive heart failure. We also have our own on-site laboratory, which we would do any CLIA wave testing, because if any of y'all have worked in a clinic setting, with this vulnerable population, if you draw their blood, you send it out, you don't get it back for a couple of days, you may never get back in touch with them, or it may be a significant period of time before you do get them back in to make changes to their treatment. So it really helps us to be able to draw their lab, run the test, and be able to treat with those changes on site. Prescription assistance is another huge part of our program. We will actually sit down. We have an LVN who runs this program. She sits down with our patients, helps them fill out their applications for prescription assistance. Last year, we provided about $1.5 million in free medications for our patients. Nutritional education, which is done through our Diabetes Education Center. Also case management and behavioral health counseling. We do use licensed clinical social workers at this point for our behavioral counseling. So senior house calls we talked a little bit about. You can see some of the patient population that we're seeing in their home here. That's our nurse practitioners looking at medications with our patients, going over how to take their prescriptions. But our NPs in this program are designated as the patient's primary care provider. They'll treat and manage both acute and chronic illness. They usually make scheduled home visits. We like to see our patients about every 3 months, especially those with chronic diseases. But we are available for PRN or as-needed visits as well. We also do a lot of care coordination with this population. Health is probably the primary referrer for this program, but a lot of our patients are on hospice as well as home health. And we coordinate between the families, the community, the social services, and the home health and hospice management. The Diabetes Education Center, again, I told you about the one-on-one classes. She also does support groups, and she works a lot with us on a variety of grants. She also is very actively involved in our performance improvement process. Sunrise Canyon, here's a picture of the actual location, and it is in very East Lubbock, still a very vulnerable, underserved area. That clinic is located at Sunrise Canyon, and we have 8 exam rooms there. 4 of them are for behavioral health, for the psychiatrist, and 4 for primary care. So 3 additional programs that we have that we manage are the Nurse Family Partnership. Are any of y'all familiar with the Nurse Family Partnership or have that program? Great. It's a wonderful program. It was a little late in coming to Texas. It's been in the nation for over 30 years. It's been in the state of Texas about 7 years right now. This is a program that's evidence-based, and it was started by Dr. David Oles. And the goals of the program are to improve the outcomes of pregnant, medically underserved women and their unborn children. We use only BSN-prepared RNs for this model. That's what's been proven to provide the best outcomes. We admit the women and the families when they are... we admit the women and their families when they are still pregnant, and we follow those families until the baby is 2 years old. We provide education. It's not a health management model, but more of an educational model. So the outcome of that is to decrease child abuse and reduce jail time in family members also. Patient Navigator program is one that we are going to discuss at great length, and Chris will be telling you more about that. The Storks Nest program is also a program for underserved women and their families. It's an incentive-based program that provides incentive items to women and their families when they're pregnant or have just had their babies. If patients go to their prenatal visits, if they attend prenatal classes, then they get points and can accrue those to purchase brand new baby items.
The Patient Navigator program, we titled it Transformación para Salud because the majority of our enrolled participants in this program are of Hispanic origin, and a majority of our community health workers are also Hispanic. So we thought that title was kind of appropriate. Before I proceed, I would like to encourage you all to ask questions. Let's make this an interactive session instead of us doing the presentation and then asking questions afterwards. If there are any burning questions as we go along, please don't hesitate to raise your hand and ask the question. This program is funded or was funded by the Bureau of Health Professions of HRSA. And we actually had 2 cycles of funding. The first one was the demonstration project, which took place in 2008 to 2010. And then we were lucky enough to get post-demonstration program, another 3 years of the program from 2010 to 2013. We just finished actually the program, and we're in the process of continuing to analyze the results or the outcomes of the program, which some of the preliminary results we will share with you this afternoon. As we said, is based on the Clinical Services and Community Engagement Program of the School of Nursing, and it focuses on vulnerable clients of the ComBest Center, primarily living in Lubbock. And we use a conceptual framework that was developed at the School of Nursing. And we use this conceptual framework, we used it for planning, we used it for implementation, and we continue to use it for evaluation. And so I would like to spend a few minutes with you discussing the framework, the conceptual framework itself. This grew out of the need for an approach that was needed to help patients change or adopt healthy behaviors by themselves and not for them by others. And it is based on the educational philosophy of Paulo Freire, who was a Brazilian philosopher. How many of you here have heard of Paulo Freire? Wonderful. There's at least 4. So we were very impressed, and we thought that his philosophy was not just an abstract concept, but rather something that can be applied and actually help to facilitate on the part of the providers to facilitate behaviors of the clients, but really the clients or the individual or individuals are the ones who would make that or undergo that change themselves. His work came from his exposure to oppressed minorities in the favelas. The favelas in Brazil. Favelas, I think, is the slums of Brazil. And his concept of transformative power was very compelling because what he says in this philosophy is that people have to really be able to overcome oppression by themselves. And it's not the oppressor that frees or liberates individuals from that oppression, but rather the individuals who are oppressed have to be the ones to liberate themselves. And it has been used in many parts of the world to help people improve their lives. Here in the United States, what I know, is a movement that really used Freire's pedagogy. Was the movement in Chicago by Saul Alinsky. How many of you have heard of Saul Alinsky? There you go, the same people who have heard of Freire. It's very inspiring to know that instead of, and I think it really helps on the provider side to understand that we cannot do for our clients, our participants, what they need to do for themselves. All we can do is facilitate their environments. And that's the whole concept of the transformational process in the Transformation for Health framework. So just very briefly, I would like to think of this as a stage, or maybe a phase, not a stage, but rather a phase where individuals have to go through a period of pre-consciousness before getting or developing critical consciousness of the realities, their own realities. What kind of environment are they in? What is their internal environment? What is their external environment? And the influence of this in their lives, in their behaviors, and so forth. And once that critical consciousness is aroused, then the individual becomes ready to make an intention to change behavior, if you will. And then after intention, then they're ready to make a decision, and finally end up with a transformation process whereby the health behaviors are realized and become maintained and become permanent. We are able to use, it's a conceptual framework. It's not a theoretical framework per se, but it is a conceptual framework which can allow the use of other theories. For instance, in our application of this in the community health worker patient navigation program, we are using the theories of trans-theoretical change. We're using social cognitive theory by Bandura. And I know that this may seem highly abstract, but actually what we would like to be able to share with you is our efforts at applying this conceptual framework and the theories behind it. So we developed a logic model for the transformation for health, and we identified as the constructs the processes or the phases in that whole process. And then we looked at the implementation phase and what interventions we use in order to facilitate the development of these process. And then we looked at outcomes, which is what we call secondary outcomes, leading to finally the distal endpoints, which is the target biomarkers for chronic disease management. And I will go through this a little bit more specifically towards the end. So this program is really to improve healthcare outcomes for vulnerable individuals in Lubbock County using certified community health workers as patient navigators. And this is yours.
So originally, Chris had mentioned that the demonstration project for the original demonstration was 3 years, and that was from the Bureau of Health Professions. We did hire quite a few personnel during that time. We hired a full-time program director. It says 0.75 here. She had some other duties, but she was 0.75 in this actual project. We had one full-time clerical person who basically was responsible for data collection and monitoring and also reporting data to the Bureau of Health Professions. And then we had 4 full-time community health workers. 3 of those were bilingual and were Hispanic, and 1 was African American, which is the majority of the population that we were serving. So the way that these referrals got made to us was through the Larry Combest Community Health and Wellness Center. Patients who were in the chronic disease management programs that I mentioned to you earlier, diabetes, hypertension, asthma, congestive heart failure, with comorbidities of depression, anxiety, and obesity. Those patients who were having difficulty self-managing their illness were referred by the nurse practitioners to this program. We have probably about 1,000 chronic disease management patients who were able, as diabetics, to keep their A1Cs under control their weight. Those didn't need that extra push that this program gave them. So the ones that had their A1Cs out of control just were not able to get their self-managed, were referred. So the navigators would actually meet them in the clinic and do what we call a warm handoff, because we felt like that was very important for our patients to meet their navigator for the first time in a secure, safe setting where they had been before. If that handoff was actually done in the exam room and they knew that their nurse practitioner really was confident in that new professional being added to their services, then they were much more willing to accept that home visit. So it's kind of hard when you get a cold call from somebody that you don't really know and they want to make a home visit. So this model worked very well for us. So you can see our target population at the center, 3.5% African American, 11% were non-Hispanic. We did have a large proportion of Caucasian, but a very large percentage of Hispanic. If you look at the bottom, 63.5% compared to non-Hispanic, 36.5%. A large percentage of our population are in that age group where there's not a lot of funding going on. That less than 20 years old, not very many, but the 20 to 64, which is where our highest population of non-funded patients comes from, that was typically the patients that we were seeing in this program. So 39% male, 61% female. So females were probably more likely than the males who were referred to accept that help. So the conditions, again, that we managed, the most common being diabetes, but the majority of the patients who had diabetes also had other chronic diseases, typically hypertension and possibly congestive heart failure. So looking at the population by federal poverty level, 59% of them were at 100 or below of FPL, 10% 101 to 150, and the chronic disease patients, you can see 424 with diabetes. So the real challenges of working with this community, the one I just mentioned, is the low socioeconomic status. That's the problem that most community health centers face, because when your patients don't have funding, there's difficulty getting their medications, difficulty getting the food that they need to eat that's best for their illnesses, and the less likely they are to have access to routine health care. We also had a problem with low literacy, or low health literacy specifically. That's one of the things that we did assess at the time of admission was their health literacy status. Most of the literature that we developed for this patient population were written at 7th grade or below level. Multiple comorbidities. You rarely see a patient with just diabetes or just hypertension. That's pretty rare. Some of these people had not had health care in 20 or 30 years, so they're a very sick population when they come to the center. Inadequate resources, whether it's food, housing, being able to pay their utility bills. A lot of them couldn't purchase medications because they made the choice to feed their family instead. Transportation issues is huge with this population. Even though as a community health center we're right in the middle of the neighborhood and some of our patients walk, transportation was still a barrier. We did purchase a van with some of our federal dollars, so we are able to go and pick up our patients at their home and bring them to the clinic for their clinic visits. As far as the navigators, they did typically make home visits. Some patients did not want you to come to their home, so we might meet them at the community center that's next door to our building. Some of them we met on their job. One of them was a roofer, and that's where he wanted to meet. He was on top of the building, and I think actually our Navigator climbed the ladder one day to actually have a conversation with him, because that is the only place that she could get him to talk to her, and that seemed to work for him. So it's really about meeting people where they are. And we put external locus of control. A lot of these patients just don't feel like they're in control of anything. Their whole life is out of control. Yes? Some of them qualify for Medicaid, but I'm sorry. The question was asked what type of funding, if these are typically Medicaid patients. We do have about a 25% overall in our clinic Medicaid rate, but we run about 45% totally non-funded patients. They're seen in the clinic on a sliding fee scale, and the service for the patient navigators is a totally free service that we provided. Okay, so our experience, we already had the chronic disease management guidelines in place for all of these diagnoses. EMDs is the electronic management system that we have in place at our center. It's our electronic health record as well as our practice management system. It was made for very small practices, and that is a system that we're in the process of changing. But that is how we document. That's how our nurse practitioners document their health visits, and our patient navigators also documented in the same record. That made it very easy for the nurse practitioners to see what had been done by the patient navigators. It also kept the navigators up. They could look at scheduling. They could see when the patients were coming in for their next visit. They could also see if that patient was a no-show for their visit, which is very important because that was one of the jobs of the navigators, was to try and encourage them to make all of their healthcare appointments. So we had a cadre of certified culturally competent CHWs, and in Texas there is a certification requirement for community health workers, and it's 160-hour training that they go through. But above and beyond that, we did another 6 to 8 week training. We wanted them to understand all of the chronic diseases that they were helping those patients take care of. They needed to be able to educate patients, to talk them through how to self-manage their own disease. Because the goal of putting these navigators to making home visits was not for the navigators to do all of the work for them. It was to be able to get the patients to be able to know who to call for different things. If we made all the calls for them, if we did all the work for them, all we've done is continue to make them dependent on somebody else. But we want to teach them how to become independent and self-manage their disease. We developed very strong institutional and community networks because you have to be able to be very knowledgeable about the social support in your own neighborhood. And every neighborhood's a little bit different, but you've got to be able to tell them how they can access food, how they can access additional funding for utilities, medications, those kinds of things, in addition to what was provided at the health center. So here's our 4 navigators that were recruited. This was our original group, and in West Texas we do have the West Texas Community Health Worker Network, which is a group of all the all the community health workers that meets routinely. They do a lot of training because there are continuing education requirements that are required, and the 6 weeks intermediate training that I mentioned to you. So experience with the training, these are the core competencies that are required in Texas for community health workers. They receive training in communication, interpersonal issues, service coordination, capacity building, advocacy, because you can imagine advocacy is a huge issue for community health workers. Sometimes I think the patients felt like the community health worker was really their link to not only health care, but to survival, I think, for a while until we got them to the point of self-efficacy. They became the teacher for the patients. So organizational skills were a huge issue for our staff, and their knowledge base. So the additional training that we gave them, the 6 weeks, is this additional training. We talked about the targeted chronic diseases that we had talked about. They don't get a lot of specific chronic disease training in their 160 hours. Clinical trials is something that we also talked to them about if patients wanted to participate in clinical trials. Case management and how to access those case management type skills through the center. We brought in trainers to teach them motivational interviewing techniques, because that's really how you draw out the patients. And building rapport is huge with this population. Sometimes with our patients, the first 2 or 3 visits is really just building rapport with that patient and family. And it was very different in every situation, whether it was just simply the patient who was involved or the patients and other family members. The transformation for healthcare model that Dr. Esperat mentioned. Class standards, our agency policies, of course. Reporting and tracking is huge when you have a federal grant. There was an organization that was contracted by the Bureau of Health Professions called NOVA, and they were responsible for the data collection and the analysis that we had to send to them. And then we had ongoing weekly training and reviews. So we looked at the provision of enabling services, and we did one-on-one supervision with our project director or coordinator with our CHWs. She met with them on a weekly basis, talked to them about their caseload, anybody on her list that was having issues. She also did reflective supervision to make sure that the CHW was able to work through those issues and didn't have any needs herself for education or more training. We primarily did face-to-face interventions. I told you the location of those varied widely, but we also did a lot of telephonic calls. So a lot of times patients were very busy. We did have several who were actually working at the time, so sometimes it was easier to catch up with them by phone. We also were very flexible in our scheduling for these staff. It wasn't an 8 to 5 Monday through Friday job. They were available evenings and weekends, because some of those patients, the only times they could see you might have been 6:30 on a Saturday night or 8 o'clock after they got off work. So they were very flexible in how they could make the visits work for the patients. So they also did goal setting. Every single visit, they did goal setting. And this was a goal not set by us, but a goal that was set by the patient. And it may just be a very small goal that week. Maybe for a diabetic who's really trying to change their diet, it was as simple as, I'm not going to continue to drink a regular Coke every day this week. Just very small changes. And as the program progressed, you would see that those patients would start setting larger and larger goals for themselves. But initially, it tended to start out very, very small. And that's what they needed to understand, is that every goal, if you just set a really big goal, a lot of times that's not attainable. So we would encourage them to do stepwise goal setting. We also used the wheel of change with the patient so that they could see that they were actually making changes week by week and progressing. The amount of time that patients tended to stay on our program varied greatly. It could be as short as 3 months. Some of the patients were on over a year, because everybody progresses at a very different rate. Our CHWs were city trained, which is our IRB process. You have to go through a special training. We also train them on the clinical trials that are available. Those were explained to patients. If they wanted to participate in any clinical trials, they were able to. And some of the examples of some of the outreach activities that they did during this period of time, they went to some of the elementary schools. We, of course, partnered with our Medicaid plans. We looked at whether patients would qualify for any additional funding services, especially that large volume of people who had no funding whatsoever. We also have a large health fair once a year We participated in many others. There was an international and a multicultural affair that we helped with, but a lot of school activities. You would see a lot of parents there, and it's typically the parents that we were going to be having on our service. So again, it was a home visitation model, and the way we set it up originally is the navigators would meet again in the clinic if that was possible. If not, we wanted the provider or the nurse who they were very familiar with to make a phone call to that patient to actually introduce the CHW. Then we set up weekly home visits initially, and it was weekly until the patient started feeling comfortable, developed that rapport, and then they were gradually extended out to every 2 weeks, and then monthly prior to being discharged. There was a lot of interaction, especially with the clinic staff, the nursing staff, the nurse practitioners, and the community health workers, because what we did was just bring the navigators on as an additional team member, not making that just a separate team. As far as referrals, you never know who's going to walk in as a walk-in patient. So we did have navigators present on our really busy walk-in days in case there were patients who needed to be referred to the clinic, to the navigators. So that way they could just come right into the exam room and have the nurse practitioner introduce them. And that worked out very well for us. We've talked about the different locations that we went to, pretty much anywhere where the patient wanted to meet us. I think there was one that we met at Dairy Queen. Not too many Dairy Queens left in our part of the world, but that was a location where that patient felt safe. Sometimes people just don't want you into their home for a variety of reasons. You never know what's going on. So we tried to honor that and meet them wherever they were. So some of the typical interventions that we did based on the interventions from the survey tools, we looked at social things with the patients. We tried to help them really think about who their social supports are. Because sometimes you ask that question, do you have anybody who's really close to you that's helpful to you? And they'll say no. But if you really start getting them to go down through the list, most of them find that they do have someone who is able to be there as a support for them. Assessing identified resources was huge. A lot of these patients didn't have access to food, much less healthy food. So we did provide food bank vouchers for those patients who needed food, as well as passes on the bus if they needed it. So we've talked a lot about supervision and the ongoing training. But one of the things that I think was most effective with this grant is we developed an interdisciplinary team after we added this service. Once a month, we got our nurse practitioners, our physician, our medical director, our social workers, our nurses, medical assistants, billing personnel, scheduling people, navigators. We all had them in the same room together. We talked about the very complicated patients, or maybe the patients that we were having most difficulty with, maybe helping them reach their goal. We would pull up our EMR on the screen, go through their lab work. We would go through their appointment history, determine interventions that we needed to make from there. Because our navigators are not medical providers. They needed that medical expertise. And also, if you've got the scheduling people there and your front desk people, the front desk people know the patients really better than almost anybody. They talk to them on the phone. They greet them when they come in. They greet them when they leave, tell them goodbye, and always ask about their family. So they felt very comfortable with them. But a lot of times it was that reception person who had a tidbit of information that was very helpful for the medical team. So that interdisciplinary meeting was a great resource for us. Then we have what you see up here called ELCI. That's East Lubbock Coalition for Community Health Improvement. That's a community coalition that was started jointly with the community center that's next door to our building, Harwell Elementary. We actually are on the school grounds of an elementary school in East Lubbock and the School of Nursing. But it's just people who are interested in the health that's of the residents of East Lubbock. There's people from the Department of State Health Services, from other programs, and we get together on a quarterly basis. This group has also supervised grants in the past. One of the USDA obesity grants, they helped coordinate for us. So some of the lessons learned is we really felt like we were very fortunate to be a part of the demonstration project and then to be awarded another 2 years for this program. And you'll see when we go through some of the measures, the importance that it played in the patients' lives also. But it really helped us evaluate our community health worker program and the additional training that we've given those staff be above and beyond that 160 hours. I think the weekly goals that we developed with the patients were huge. I don't know that people always have somebody sit down with them and, let them actually teach you how to set a goal and understand that small goals make a huge difference in an outcome. We also had a huge commitment with the patients. We did find a few patients, of course, we might see them one time, and they really were not interested in the program and didn't want to continue with it. Some of them felt like they didn't have the time commitment, and again, some of them didn't want people in their homes. Accountability was a real must for the patient population, because what we tried to instill in them is what Chris talked about with this model. It's not to do things for them, it's to teach them to be responsible for their own health and to make those good decisions. So patient accountability was huge, and I think a lot of patients learned that accountability. And the interdisciplinary team, I can't tell you how valuable that was, not only for the community health workers and those specific patients that were discussed, but it really was very valuable for the entire team to be in one room discussing a patient and how we can all pull together as a team and make changes in the patients. Okay.
Thank you, Linda. I think this is one of the objectives for our presentation this afternoon, is to share with you the outcomes of the demonstration program as well as the post-demonstration program. So these next few slides shows you the clinical and behavioral outcomes of the original demonstration program. And we were very happy to see that there were successful outcomes, particularly in the clinical outcomes, particularly hemoglobin A1C level. But then, the literature also shows that that is where community health workers are really, the data supports the fact that they are effective in lowering hemoglobin A1Cs or promoting the lowering of hemoglobin A1C. So we had statistical analyses done of the data, and so this one was definitely statistically significant. We had patients who were assessed for changes in blood pressure readings prior and post navigation with significant differences noted. And patients who had, this was one area where we couldn't make a dent, the BMI. We had patients with really BMIs, some of them over the top, and we were not very successful at all in lowering BMIs. But then some of these patients were started on diabetic medications, and as you know, as clinicians, some of you here who are clinicians, you know that when you start patients on diabetic meds, they do gain weight. So this is probably going to take a much longer time before we see changes. Lipid panels showed a slight reduction. This was not statistically significant, but a definite reduction in the averages. And so these clinical outcomes showed that the demonstration project was moderately successful in obtaining improved results in the biomarkers. Now, the behavioral outcomes, on the other hand, we were very, very happy because we think that behavioral changes are very important in impacting the clinical outcomes. Without the changes in behavior, you're not going to see changes in clinical outcomes. So this is probably some of you may not be interested in the statistics, but these are the outcomes that showed statistically significant results. Self-efficacy in diabetes, the personal resource inventory. This shows you the social support that patients had and their use of the social support. Self-efficacy for managing chronic disease. These are all standardized exams. Social provision scale form, which showed a significant item in that scale that was obtained, and the summary of diabetes healthcare activities form. So these are, we were very happy with the results of these. So in terms of the post-demonstration program, we did again clinical and behavioral outcomes evaluation, and this may not be of interest to you, but it does show. We did a growth curve analysis, which is a more or less sophisticated statistical analytic process, and so we showed a definite significant drop in hemoglobin A1C, and in the blood pressure, it was the diastolic that was affected. The systolic did show significant changes. So some of you here who are clinicians may have some explanation as to why that not the systolic but the diastolic was significant. And the behavioral outcomes of the post-demonstration programs again showed these results of these scales to be significant in the post and the pre-navigation program. So these are the histogram or a graph that shows the improvement. And again, the statistical results of the post-demonstration program reflected and validated what we showed in terms of behavioral outcomes of the demonstration program. So I said we would review the logic model, and I'm going to show you a short video after this that really shows the use of one of the tools that we have, and that is the Wheels of Change tool for plotting the progress of the patient in terms of the change in behavior and the intention to change and the decision to make the change. So this is what the outcomes were that were measured, that was shown in the analysis of the behavioral outcomes. And so the distal endpoints, target biomarkers, we thought that we were really successful in obtaining the targeted biomarkers. So here is the video. This is one of our patient navigators who conducted a home visit. We obviously got permission from the patient and her husband to video them. Okay, how do I do this? Okay, here you go.
Habits. Okay, and then once you learn more about...
Oops. Oh.
Let's see what we can figure out.
I think you just... Oops. Sorry about that. There's always these glitches. Hopefully you will be able to see the application of the Transformation for Health framework in this short video. Okay.
Habits. Okay, and then once you learn more about it and you're more aware of it, then you start preparing to making that change. Changing your eating habits, changing your sleep habits, changing things like that. And then, a little later, you start taking action as to making that change. See, she took action when you start back taking her seizure medicine. Oh, so that was an action that she took. And when you take your action, then you can maintain the change. Are you still... This one. Okay. See, she's maintaining the change, and then her change becomes permanent. After a while, it's just like she's doing it naturally, you know. And when it's like that, this is where you are in total control of your illness.
Okay, the next one. There's another one.
Yeah.
Oh, see that?
And you know,
aren't you proud?
You know what happened? What happened, you know, because of her potassium. In other words, she didn't have one, but her potassium went high. That's the reason.
Yes. And how you can explain to me now how you are controlling your potassium.
Just not eating things that have too much potassium.
Oh, so you may...
I have to read the...
So now you're reading labels? And
so
you're eating...
Stay away from potassium, you know, most...
Yeah, because her body maintains it.
Especially the...
Because even though I do with potassium myself, you know, she need to watch it, you know. And
I know I have to have a little potassium, but I produce it myself, and then what I eat,
yes,
makes
it go up.
Last time you came, I mean, I told you that.
Okay, this is a very typical interaction, not just with the patient, but with the patient's husband or spouse or significant others. They're usually part of the whole home visit if they are there and if they want to participate. So I hope that gave you a flavor for the type of intervention that was developed and implemented in this program. So I think we're right about time. Yeah. If you have any questions.
For questions before doing things in depth. Before we do that, or while we're doing that, if people have some of the free surveys, I'd like to collect some of those just to do that, and then we can. Thank you very much. So while I'm doing that, our first question, and make sure to repeat the question in the microphone.
All right. First of all, I want that Navigator in all of our clinics. I thought she was fabulous. But I was really interested in the self-efficacy instruments, and I couldn't see how many measures were on all those. Were there any barriers to asking those additional questions, and how was it administered?
The question was the use of the self-efficacy tools for measuring patient progress through the Transformation for Health process, and whether or not there were any difficulties in getting data for the self-efficacy. We used the standardized instruments that developed in Stanford with Kate Lorig. How many of you here are familiar with Kate Lorig's work? So we used the very widely used standardized instrument, and it's very user-friendly, and it is very limited number of items, but has been validated to really be measuring what the self-efficacy construct measures. And most of the time the patients have no compunction about filling up the form or having if the patient is of low literacy, then the patient navigator does the survey with them and does the measurements. So we measured them over a period of time for several measurements?
One of the things that we did up front when we set up our protocols, there were certain forms that were done at different time periods, but that was pretty flexible because some patients, weren't up for doing 5 forms at one visit, and it may have just been one form that they did this week, and so that was really gauged independently at each home visit.
It says you're in the second phase of funding right now. Is that it?
We just completed our second phase of funding.
Okay, so what are your plans for sustainability, particularly paying for your community health workers?
The question was sustainability and how we plan on sustaining our community health worker and Navigator program. That is something that has been written into every grant since we started this program. Because we weren't sure of the outcomes initially, but it is a program that we're putting into our community health center as a routine. We even are working on a Strong Start grant that's for pregnant women to improve the preterm birth. We're even using navigators in that program. We're putting navigators in our evening clinics just as a routine part of the clinic, so they're being absorbed within our clinic operations.
Yeah, and that is really key to the sustainability of the program, and that is institutionalization of the program. We believe in the effectivity of this, but what we are also hoping for is that the state of Texas will recognize, based on outcomes, based on the movement, the community health worker movement, that they will devise some way of reimbursing for services of the community health workers. And we're fairly optimistic that the Affordable Care Act implementation, full health care reform, will make way for, hopefully, that process. Yes, sir.
Is it possible to see the slide just before lessons learned? And secondly, will the presentation be made available online or in some other form?
We would be very happy to share. There was a question on whether the slides would be available. We would be very happy to share it, but I'd like to ask Casey if we have a website where we can post the.
Yes, yeah, all of the presentations from all the breakout sessions and plenaries from this symposium will be posted to our website, chpfs.org, as well as our partner organization, nchph.org.
Yeah. And also, if there are any of you who are interested in either sharing your own experience with community health workers, patient navigation, or are interested in starting a program like this, both Linda and I will be very, very happy to share with you one-on-one how.
Anyone who'd like to get in touch with, any of our presenters, could contact me. My name is all over the registration information, things like that. In case y'all are interested, we can put you in touch.
Thank you, Casey.
And I think you had a question. Did you have a question about this slide?
Oh.
I wanted to see it.
Okay.
I didn't see it before you passed it.
Okay.
Lessons learned. We will definitely make that available also as a separate slide if you wish. Yes.
Well, I was asking about the presentation you made available. I think you answered that.
Yeah. Okay.
Now that your second phase has ended, what is going to happen with the four navigators, help desk workers that you have, and are they going to be able to get other employment issues too?
Some of those, when they knew the grant, the question was sustainability again of those navigators that we had on the program. As we were phasing out the program, 2 of those navigators chose to take other jobs in other areas, but the others were offered other positions. Right now we have 5 community health worker positions that are available instead of just the 4 that we had prior to this. And we have several other grant opportunities with other community health workers in them. So,
the reason I asked this is not only sustainable for the project, but for the community having
correct.
Employees.
Correct. Correct. And also those patients as they were phased out, still we want to have someone available to continue those services if we need them.
And as far as upward mobility for the community health workers, remember these are certified community health workers and they're ready to move up the professional ladder if they so wish. So one of our coordinator of the program has now received her PhD, or is on the verge of receiving her PhD. She's not with us anymore, but we truly supported them in their career aspirations and goals. And the other one is in a bachelor's program, and some of them want to stay being community health workers and not having to face. Remember, these are full-time positions, but also these community health workers are full-time moms or grandmoms, and so there are different aspirations and goals that they have in their own trajectories. So we support them in whatever we can, in whatever way we can. We allow them, their schedules are very flexible, so we allow them to attend their classes if they're enrolled. And we also provide for continuing education of the community health workers. So we send them to continuing education programs throughout the state, if there are any, and if it is appropriate and if it will enhance their skills. We support them. We actually support them financially to attend these workshops. Any other questions? Yes, ma'am.
Now, you did mention that this is an expanded program. What kind of oversight did you have in terms of, do they have to have a certain number of charts full-time for the position? What kind of arrangement do you need to make sure that some things?
Right. In Texas, the question is, what kind of oversight do the nurse practitioners and the nurse managed center have? We do have a collaborating physician who is a family practitioner, and she provides that collaborating physician authority for our nurse practitioners. She is on site at least every 10 business days, does review 10% of each one of the nurse practitioners' charts, and she's available 24 hours a day for our NPs for any questions that they might have.
Yeah, it's based on Texas law or regulations governing the advanced practice nurse practice.
And she was very complimentary of this program, very excited about the changes that we saw with our chronic disease management patients. So she actually referred some of her patients from her other practice to this program.
May I please see your transformational process?
Sure. The question was about reviewing the transformation process.
Yes, this one's not a navigation question. It's back on your organization. You had mentioned the Storks Nest.
Yes.
One of your programs. How do you sustain that?
Okay, the question was about the Storks Nest and the sustainability of that program. That is a grant-funded program through March of Dimes, and it's 100% funded. This is not a program that's open 8 hours a day. It's open 4 hours a day at this point, and it's also staffed with a community health worker as the person who's that first line of contact for that person. We see an average of about 80 to 95 new patients a month in that program. So this has been in existence for 10 to 15 years, and that may be longer. We've been involved with it for 5 years. We do a lot of fun activities. There's an annual baby shower where the community gives new baby items to the Storks Nest, and that's how we get most of our new baby items. They're all donated, but they all have to be new items.
Are there any other questions? If not, we want to thank everyone for being such enthusiastic audience, and we hope if you have any plans of starting a community health worker program, patient navigation program, that you will be successful. Thank you.